Welcome to another edition of no longer the Jaw Complex. We changed our name to Airway Ortho to better reflect our branding and make it easier for all of our patients. So Airway Ortho on YouTube instead of the Jaw Complex. So welcome back to another edition.
Airway focused orthodontics is, of course, a means of enhancing the jaw complex.
Going to be answering some FAQs today. So, Dr. Newaz, why don't all orthodontists provide adult skeletal expansion?
It'll either be because they don't know that it is possible, or that they don't agree with it, or that they perhaps do believe it's possible and do agree with it, but they simply don't want to be the ones performing or recommending. And I think orthodontists can fall into any one of those three categories, plus, of course, the category where you are recommending it and doing it or providing it in some capacity.
And do you feel like some orthodontists don't even know about this? Or
I do. I think that some don't know about it. Well, I think for them to be totally oblivious about it, I think that's probably not really a thing anymore, at least. I think now you see this thing show up in all kinds of conferences and articles and stuff like that. So you'll see it, and then where you position yourself opinion-wise with respect to it, I think is where now you can start to stratify orthodontists in terms of their attitudes towards MARPE and skeletal expansion.
Do you think that the more orthodontists who learn about MARPE would be less likely to be as aggressive with retractive orthodontics?
Great question. I think it's in some ways perhaps an oddly specific one, but I think that yes, I think if people know that skeletal expansion is possible, I think that will happen to reduce the incidence of retractive or constricted mechanics, or
because the philosophy is completely the opposite.
Exactly.
So if they're believing in expansion, forward movement, then they probably don't promote retractive extraction orthodontics. So I think that the tide is starting to turn more towards expansion and protraction versus retraction and extraction.
I'm not sure if this is a relevant question. You guys can decide whether we're answer this or not. But when you guys were in dental school, did you learn about MARPE? And if not, do you think it should be integrated into as the standard of orthodontics?
Well, so MARPE wasn't really a thing when we were at dental school. Dental school was so a couple decades ago, right? Drake was probably starting his rap career, okay? And then when I was an orthodontic resident, then it was, I did my orthodontic residency from 2016 to 18, and during that time, basically you had to be a very early adopter to basically use and know about maybe Juan Moon's MSE, for example, as a evolution of very sort of early rudimentary types of MARPEs, where you'd maybe put the tats in first and then try to retrofit some other thing to fit on top of those and somehow expand with a couple just random tats or something like that, right? So MSE was a more, like, hey, this, these tats and this system and this ratchet to put it in and whatever is, a thing, and it's a system, and you can use it to try to achieve skeletal expansion in your adult patients, right? Of course, also on children and teenagers, but also adults, right? So that was kind of a new concept, more or less, right? Where, when I came out of residency in 2018, I was like probably one of the only people that did that kind of thing, right? But, right now, obviously the field has moved to light speed in the last 70 years. And so now I think there's obviously a lot more of that recognize and buy into. As far as whether you think that it should be, or your question, whether we think that it should be a cornerstone of orthodontic education and a profession, I'll never say that any one particular modality should be the profession or what it centers around. But what I will say is that whether it should be taught and its utility more so. I think doing them and performing them, I think that's a choice that orthodontists should be able to make for themselves. You don't have to offer it in your own practice to at least then evaluate a patient and be able to tell them that, hey, this thing exists that may have a utility in your case. You should go talk to XYZ provider that might be able to do that for you. So that's that's what I think it should be educational, is that basically all orthodontists who graduated from orthodontic residency programs should have at least a well-developed awareness of the therapeutic potential and also the demerits of MARPE and MSE and all these kind of things, right? The demerits of skeletal expansion as it exists today, I think people should kind of know, like, hey, these are pros, these are cons, these are,
and if it applies to
case selection.
As a general dentist, we see patients coming in with class 3s or underbites or cross bites, and general dentists kind of don't really know what to do. So they'll just punt it to an orthodontist, and if it goes to an orthodontist that doesn't perform this and believe in it, then the patient's kind of, they don't have options.
What would typically happen?
Literally, if a patient has a class 3 or an underbite, they'll get punted to an orthodontist.
Like
down the street.
extractions occur?
Extractions, or the orthodontist will send them straight to the oral surgeon to get an evaluation, and they'll make a 3-piece Lefort cut. I think as general dentist, you should still know that there are options, and if you don't do it, that's fine, but you should know that there are orthodontists and other GPs that do this. My first experience with it was, I still did standard orthodontics Invisalign, and I did retractive carriers and things like that. So this one patient that I vividly remember, treatment plan doing IPR and pushing her teeth back, and she just never came back in for her reconsultation. So she came 6 months later for her cleaning, and she had this contraption in her mouth, and I was like, "What the heck is this?" Because we never learned about it, and I think I think I immediately called you up. I think the patient was probably still in the chair. And I was like, "Bro, what is this?" And that was, Dr. Evans, she's a leader in this realm too. And she had done that on her patient. And that patient is still a patient of mine for general dentistry. And she has a great, successful outcome. And that was my first experience with it. And since then, I've seen, all of our cases, hundreds and hundreds and hundreds at this point of expansion results and successes. But I do think that GPs need to know that this thing exists, and that orthodontists should know that they have an option to do it or not. As an athlete, when should an athlete get expansion, and can they still play and practice with an expander?
Yeah, I think for the most part, there's pretty much no contraindication to being able to do non-face contact physical activity with an expander. And as to whether it's so that's just contraindication wise.
So like
okay.
Jiu-jitsu, Muay Thai, boxing.
Don't get kicked or punched in the face.
Yeah, like physical, like
skull bones open. Right, it's probably not the
like martial arts. You should definitely not do that.
Greatly increase your risk of,
or anything that you may,
increase the risk of.
Well, increase your risk of basically the expansion departing from intended behavior, right? Obviously, asymmetries and this and that. You get smashed on one side of the face, well, that's going to affect how your skull bones react to expand.
It's not a risk worth taking.
Correct.
Right? So even if there isn't an outcome, we still wouldn't want to trial it on a patient. Yeah. Helmets, if you wear a helmet, I'm sure that's a little bit more acceptable. Right, if it's football or something like that. But even, people get elbowed in basketball, right? People get headers in soccer, right? So that's something to consider is,
Yeah. Yeah, I think, in general, the considerations for being an active sport and undergoing expansion are that generally it's okay. You certainly want to protect your mouth and face with whatever appropriate gear that you have, whether it's a mouth guard or helmet or whatever protective gear that would customarily be there. And the other consideration is, of course, the ongoing orthodontics or the bite. A lot of patients who do expansion will eventually transition to braces or Invisalign, and just having, again, people have been doing sports with braces and Invisalign for a long time, right? So we have just routine ways to protect people from those with mouth guards is that whatever. So that's, of course, important. And a lot of our patients that are undergoing like this functional airway kind of focused orthodontic stuff with respect to expansion being somewhat temporarily disruptive to the bite. Sometimes our mouth guard might be something in the form of like an orthotic type of device, right? Or something that is easily adjustable, but makes up as a buffer for inconsistencies in the bite. And we, of course, now just kind of going into like a step further, of course, what is the effect of putting the bite in a particular position? What effect does that have on the nervous system and on someone's postural stability? Maybe that can be a performance enhancer to be able to get better postural stability via an orthotic that takes you out of an offending position for the jaw as it pertains to the nervous system. We have nerves and blood vessels and depth of our jaw joints and so forth. And if we're impinging them or compressing them in inopportune ways, then the central nervous system doesn't like it. We, of course, can provide tools to decompress and protect an individual from those types of positions, thereby rendering an individual's opportunity to be more structurally upright and posturally stable.
Just to basically recap, martial arts, stay away from that while you're actually in active expansion. The expander will still be in there while it's consolidating. At some good milestone, you should be able to resume.
So wait until you get into orthodontics, essentially. Like wait
Pretty
until you
much.
get into the braces or Invisalign to start back up.
Yeah, pretty much. Dr. Newaz, what are some of the benefits towards nasal breathing with expansion?
One second. Dr. Jaffari, what are some of the benefits of nasal breathing?
Dr. Newaz, what are some of the benefits of nasal breathing?
So, Dr. Jaffari, what are some of the benefits of nasal breathing when it comes to expansion?
I like doing the interviewing.
Let's kind of go back and forth a little bit. I mean, I think you'd be good at answering this question for the purpose. So, Dr. Jaffari, what are some benefits, whether performance or otherwise?
Nasal
breathing with expansion.
I mean, we see that when patients do expand, you're opening up, we talk about this over and over again, the floor of the nose, the roof of the mouth. And so what we see is, you get better nasal breathing because you have, the kind of what I demonstrate to patients is, let's say you have a triangle, right? And let's say you have a deviated septum or large turbinates. When you expand the whole triangle, the impact of that deviated septum is lesser than large turbinates or any, anomalies within the nasal cavity, right? And so we oftentimes even recommend doing expansion prior to ENT surgery. Because if we're expanding the whole nasal cavity, then the impact of the contents inside the nasal cavity could be less. Now we're saying coulds and maybes because, it's a dynamic between each patient. But if you expand the skeletal portion of the nose, we do see some benefits for that.
And when we're expanding the skeletal portion of the nose, I guess what is it that's happening? I mean, is it that air spaces in the nose are just, how are they getting bigger? Is it related to the nasal cavity being that sort of triangular, pyramidal structure? What's actually moving in the nose?
Yeah, so basically when we talk about this in layman's terms, you're basically expanding the floor, and then you're also getting an anterior projection too, right? And so the space, so what we kind of also see is patients that, let's say, have allergens or allergies, right? Because the whole contents have more space, the impact of all those things go down as well.
So, less
nasal resistance, less irritation to the nose, more basically free-flowing air in all honesty.
What benefits come from more free-flowing air?
All the nasal breathing benefits, the nitric oxide, things like that.
How can that benefit an athlete?
Oh, absolutely, an athlete. I would say there's a multitude of different benefits. Nasal breathing affects performance. You get the nitric oxide. You don't get sick as much. You get less mouth breathing, right?
Lactic acid.
I don't know about the lactic acid. Can you touch on that?
Like VO2 max, stuff like that, 'cause that affect like your performance, like muscle, more oxygen from muscles can affect your ability to perform, go further, lift harder.
Absolutely. I mean, most athletes prefer nasal breathing.
I guess it's kind of like endo. There's probably not like a whole lot of research about it, but
There's no research on the subject of whether, of course, what we're talking about. We don't want, I guess, something specific like VO2 max and all that, right?
I can't.
We don't know if palate expansion increases VO2 max.
right.
But
We don't want to make that claim right now.
Yeah.
I would say a lot of those, like how he's talking about the FMA, we don't have the research, and we are doing that research. We're starting to do that research.
I tend to bundle like curing sleep apnea, like some of the research when it comes to CPAP or jaw surgery. Like the benefits you get from increased oxygen from that. I feel like it's easy to just throw MARPE into that pocket of better breathing, better sleep, better this, better that.
We're all on the same page, but the research isn't there. So
Or
right
MARPE
now,
specifically.
yeah, expansion, MARPE, orthodontics,
Yeah.
all the above. And I wouldn't want to make that claim, even though we believe it.
Yeah.
It needs to be, the proof is in the pudding. That's why
research
that's why we're doing the research study, right?
Right.
Because right now with MARPE, our prescription for MARPE is you have a crossbite, underbite, deficient med face, right?
Yeah.
And we're fixing that anatomical issue. We're saying that a lot of our patients get UAR's benefit.
Yeah.
A lot of our patients get better nasal breathing. Our patients get
Nasal breathing is a little bit distinct from the others. I think nasal breathing is a pretty reliable, like you get better nasal breathing with expansion, and that can be a primary indicator.
But this is a research still, right? With a custom MARPE or an FME.
No, but that.
So you know what I'm saying though? Like, you know what I'm saying though? Is like, yes, we see it anecdotally, but that claim, like right now, we're still orthodontists and general dentists are doing it
Sure.
to correct an anatomical deficiency, period.
Yeah.
You got my point?
So we can't.
So when
Are the anatomical deficiencies that we can treat? They don't just have to be in the occlusion. They can be nasal.
yeah,
At least, at least I kind of operate on that premise. Yes, I'm an orthodontist, and my job is to treat malocclusions. But one of the structures I'm treating is the base of another structure. And that structure,
share the same wall.
it's just literally, you're lateralizing the walls of the nose. If you lateralize the walls of the nose, then you are increasing nasal patency. I think, I don't care what the research says. I can make the claim that palate expansion
You can see it.
improves nasal patency. Now, whether that results in a clinically significant impact and improvement in nasal breathing as far as measurable by rhinomanometry, computational fluid dynamics, that maybe needs some research. But that's one of those things too. One of the things that I've hung my hat on as a clinician who values evidence-based work, but also wants to push and challenge staunch adherence to evidence-based practice. I think staunch adherence to evidence-based practice means a lot of people don't get better. Okay. And that's just something I believe. And that's something I believe because I see it every day. And obviously, if we're just following evidence-based practice, then it is okay to do a lot of things that obviously we don't believe in. Why don't we believe in those things? Because we see that if we're, again, stuck in the evidence-based paradigm, right, then we don't have any way to isolate the variables and the causality of extractions and retractive orthodontics, for example, that again is acceptable based on evidence-based practice, but you have a...
Which can be skewed.
Exactly. You have a TMJ or airway focused practice. Anybody that does, whether you are, us or, friend and colleague, Dr. Geld, right? All of us will tell you that a good chunk of our patients in any TMJ focused practice will be people who have had extractions or retractive orthodontics disproportionately.
Yeah.
Right. Disproportionately. And so some of those observations at least should be the impetus to seek evidence outside of where the evidence has already been established and gathered. So we are evidence seekers as much as we are evidence adherents.
In that same realm, is it appropriate to state a claim that these things could hypothetically lead to
Absolutely.
Yeah, we definitely do that.
But this is, while in the same breath saying this is a hypothetical. Do you think that's healthy? Do you think that could progress? And do you think that could provide hope to somebody who could potentially want FME or be convinced to get FME, like an athlete or somebody who's on the fence or thinks jaw surgery is the only option?
I think to say that something could be the case is at least, yes, it is perhaps a source of hope that perhaps something that is undoing that effect structurally, maybe there could be a benefit in that. That's one aspect of it. But then the other aspect, then now to balance out our viewpoint on this issue, is that not everybody who undergoes or has a certain type of treatment, suffers the same consequence. Just the same way we actually do something good and not everybody also experiences the same positive outcomes.
That's right.
Right. So this is just us being factors and being honest. Okay. Like we can do the same positive intervention on 100 people. Not all 100 people are going to get a positive clinical outcome.
And to the same extent.
Yeah. It's just like it shouldn't, basically being a doctor shouldn't be about shit like making claims. It should be about taking the information, taking the individual that's in front of you, and using what you know scholastically and what you know experientially and what you believe in terms of what healthcare means to then make decisions to help that person, make referrals to help that person, coordinate care to help that person. That is what being a doctor is. I think a lot of doctors are very staunchly evidence-based.
Miss that. It's not a one-size-fits-all, right? And how we treat any of our patients. And I think that what differentiates us is we'll actually listen to our patients. And, what we say is our patients know their body better than anybody else. And so a lot of doctors will discount what a patient says. And what we do is we actually try to listen to our patients and make sure that, we're doing what we think with their help back and forth as a team to do what's best for them, right? And that's not easy on our part because it's a lot of communication and a lot of execution as a result of that, right? So versus you have a one-size-fits-all, you kind of chunk everybody in and you kind of go with that. That's what's our differentiating factor.
So advocating for patients
Correct.
of their benefits from their perspective while calling for more research.
Correct.
Is the approach you guys are taking.
Yeah, our goal is,
While
now,
maintaining credibility of course.
our goal is now that we're seeing so many patients and, we're starting to do the research, this would be another study that we could do, right?
Yeah.
If we have more patients coming in with extraction, retraction, orthodontics, then we implement something like this. Can we measure their outcomes? Can we then come up with our own study? This is what we saw with patients that have retraction, extraction, orthodontics, and this is how we've benefited them. Then can we make a claim? Absolutely. I think that's fair. As of right now, we're still working through those experiential components right now.
So, Dr. Jaffari, what are the...
Well, time out. Do we have other questions?
We have two more questions.
No, do we have other questions?
No, that doesn't matter. I think we're in a real flow right now, so I want to capitalize on this real quick. So, Dr. Jaffari, what do you think are the hardest aspects of your job or our job as dentists, orthodontists who are trying to make a difference with Airway and this and that? Obviously, our job and our patient base comes with some demand for a little bit increased attention and diligence and all of that. So what would you say, what are some of the hardest parts of our job, and what would you like patients to know about some of the struggles we have as providers?
Yeah, no, I think what like I just said, our forte is listening to our patients and coming up with a customized solution for them. But because we do that, that's also a difficulty too. We try to go above and beyond for all of our patients, but each patient's demands are different in terms of their anatomy, physiology, but also behavioral component too. Each patient, may have their own interpretation of what they need, what they think they need versus, what they may actually need. Because we try to customize their solutions and try to be almost over the top sometimes with communication, it gets very challenging. Let's say you were to go to your normal orthodontist or dentist, you don't have as much hands-on back and forth, and we try to do that, and that is challenging for our lives, genuinely, because we're always on call, we're always answering phone calls, we're taking virtuals, because we're doing this for all patients all around the world, sometimes up to midnight, waking up early, traveling for our patients. So those are some of the practical considerations for the two of us that I'd say majority of dentists and orthodontists don't go through. And the reason why we do that is because we genuinely believe in this. We really want to help our patients out. And each patient that we're helping out is a step in the right direction to helping to bring this to humanity. Because we genuinely think that by doing expansion and protraction, we can help breathing, sleeping, and bringing this from dentistry to medicine is, I think, the next frontier. And so, when people ask us, you guys travel so much, you guys work so much, yes, we do, but it's because our life mission is to take this from dentistry and ortho to actually medicine and to provide permanent solutions for breathing to our patients. Is it easy? No, it's not. It's challenging on our families, it's challenging our wives, our social commitments. I mean, it's challenging to literally have a social life because we're literally working all the time. But this is our life mission. This drives us. And I think that when we look back in our careers, if we can bring this to humanity, I would say this is a successful career.
Yeah, I think so. And this is a reminder to our viewership that this programming is intended to be the most candid, unfiltered, sort of doctor perspective that you could get with this stuff. Okay, the work we do, like Dr. Jaffari said, is not easy. Okay, and a lot of the clinical challenges we're presented with is not easy. And we ask if we have critics out in the universe, right? Whether they are, patients or whether they are other providers, right? We kind of gently challenge everybody to say like, hey, well, how would you deal with this? And we intend to learn from the answers to those questions. Okay, this work is difficult. A lot of what we do is a best effort to address an individual and their problems, their clinical problems, their anatomy, and their behavior, right? And, we, of course, see the very vast majority of our patients are very appreciative of the work we do. Sometimes that can coexist with also being difficult and needy, and that's okay. I think we're better equipped to, handle needy and difficult patients than almost every other doctor, out there. Okay, but and that's not intended to be said with any sort of pride or anything like that. We just happen to see that we're often in that position, that because of perhaps communication related things, people may prefer our doctorship style. But does that always make us the better doctor, the one with the best solution? Not necessarily. Okay, we're doing the best with what we have, with the knowledge we have and the resources and the personnel we have. And we're not always going to be perfect, but we sure as fuck try our best.
We do so much expansion. Yeah. I think we're probably approaching about 100 FMEs delivered. Mm-hmm. We did 11 expander deliveries in 7 days. So we do a lot. We make it, and not to say that we're like super special, but we make it look easy because we do so much. Mm-hmm. But this is not easy stuff. There's a lot of variables there's a lot of moving parts, literally. We have to get your bite right at the end. We have to make the aesthetics look good at the end. We have to make your, make sure that your TMJ and the symmetry, everything is on point. And so although we do a lot, we make it look easy, it's actually not. I'm gonna say this for all of the leaders in our realm, like the same expander docs, we all make it look easy, and it's not. And that's another reason why a lot of orthodontists don't want to get in, because it's very risky, it's tough, and these cases last 18 months to 2 years to 3 years. There's a lot of tail. And so, I think our patients should understand that it's not easy. There's a reason why that many people don't do it yet. And even when it becomes more mainstream, I don't really see that many people wanting to do this, because it is challenging stuff. I'll be honest.
And that's why I think I also want to give some perspective that this is not a pathway you take as a dentist or an orthodontist if you are looking for the most lucrative practice of your profession. Okay, again, raw, unfiltered. This business comes with a lot of overhead. This business comes with a lot of loss. It comes with a lot of expenditure, unanticipated expenditure. It comes with, this is not a path that anyone chooses for money. This is totally based on philosophy of practice.
And the impact that you want to make.
Exactly. Yeah, I mean, I could easily make more money if I, walked away from all my businesses, sold them right now, and signed up for a job as an orthodontist at a maybe a high volume orthodontic practice with a sign-on bonus, this, that, whatever. I could probably make a lot more money than I do right now.
And have an easier lifestyle.
And have a much easier lifestyle, limited to one location or region. Right. So this business, just for reference, I mean, this is, of course, welcome to our new New York location. In this office, we might see anywhere between 15 and 25 patients a day. In Florida and Vermont, we might see anywhere between 20 to 40 patients a day. And every once in a while, if we have a lot of, kind of bread and butter orthodontic patients, then we might be able to slide a few more into there on any given day. And we have a lot of assistants and a lot of chairs available. We might be able to see more patients. But basically, we run a very low volume orthodontic practice. Okay. Some of my orthodontic colleagues, they see 80 patients a day, 100 patients a day, more than 100 patients a day. And I even came across, one of the guys in our town that, they said they saw 160 patients in one day. The kind of work we do is not conducive to seeing 160 patients in one day. But if you can imagine who makes more money, the guy who sees 160 patients in one day, the guy who sees 15, 160, okay? Yeah, we'd have to try. I mean,
Yeah,
I mean, it's just the economics are not there in this kind of work.
But we do this because this is our passion,
Correct.
our life purpose, and we want to help the world. And this is our way of doing that.
I mean, there's some, we believe that there is a value in the work we do, that we are obviously doing, higher risk work and spending a lot of time. It's a very different model of practice, and we think that there's a value in that. Obviously, we sacrifice a lot to do that work, and so that is what's reflected in what the business arrangement is between patients and our practice. But that's it. I mean, the sum of all those business arrangements of patients in our practice results in a pretty modest bottom line, and that's okay. We really believe that we're building, and this is now just kind of stepping more into the entrepreneurial. Obviously, Dr. Jaffari and I have an entrepreneurial interest, not really in the running of our actual practices, but we think that there is a lot of opportunity to help people and bridge the gap between dentistry and medicine. And obviously, we're doing everything we can to be a part of that. And we have an interest in that, and we're dedicating our lives to that. And that is what you're seeing. That's why we work so hard. That's why it's like, oh my gosh, like Dr. Newaz has 5 practices and works 7 days a week. Like, how is it that we're basically doing the best we can with what we have, working in an ecosystem and a model that allows us to see and pay attention to those patients, and then of course eventually have other supporting doctors who we mentor and train into this world, which some of whom we're going to be meeting very soon if you come to our practices, and we're going to start to see that, hey, there's basically like, how can you as a clinician pay all the attention to all your patients when you're also just so busy in the actual clinic? And that's why we seek in our practices to solve the problem of being able to attend to patients by providing multiple sets of eyes to focus on your case at any given time. I'm a radiologist, I'm a consultant, I'm basically somebody who can take a patient's data and case. And obviously if I'm busy running around to all these practices and this and that, there's going to be a saturation point, right? My whole objective is to liberate myself from that saturation, from me having to be the field doctor at all my offices, so that I can actually have a space, a virtual space, where I can be everybody's doctor and pay full attention to everybody's case. Because again, the actual hands-on component of our job is not that complex and not that difficult.
And I mean, you can also specialize too, right? So,
Exactly.
At this stage, I'm doing probably 90% of the deliveries.
Mm-hmm.
And so my efficiency has gone up, the surgical efficiency, right? So if you do get a consultation with us at this point, he's doing the virtuals, he's reading the CBCTs, and then he passes the puck to me essentially for me to now review the CBCT, look at the plan, and then execute the delivery. And then both of us are doing the post-ops with the staff. And so we're kind of starting to specialize diagnostics and then surgical execution, and then the orthodontic component can be, one of our associates.
Absolutely.
Right? So each person is now starting to get even more mastery in one component, and then that patient now has 4 different eyes that are working collaboratively to optimize the outcome. And so, prime example is when Dr. Newaz is planning out a case, he'll call me in, hey, what do you think about the aesthetics on this case? Like, hey, look, why don't we could keep some spaces around the laterals, for example, and I can do, minimal prep veneers, or, do we try to build out the buccal corridors with, porcelain, or can we raise the occlusion and the bite via restorative dentistry? Those are the benefits of having super specialized people that collaborate in one practice center, right? And so I think that's kind of what we're starting to lean towards. We're starting to execute that pretty, I think, efficiently at this point.
Absolutely. And all orthodontists are trained to move teeth, and most orthodontists do a really good job of that. It's really more about the philosophy of how you move teeth, in what way, in what direction, at what time, and what is possible or not possible. That's really what differentiates, honestly, most orthodontists, just in a nutshell. And so obviously the doctors that will work with us will share the philosophies of non-retractive treatment and this and that. And of course, no doctor needs to micromanage another doctor's sort of treatment philosophy, but at least the macro aspect of people being in this ecosystem will be philosophical alignment, right? And that philosophical alignment, basically, we would hire people that I would trust to, move my own teeth. Right. I'm in need of a lot of tooth movement, and I'm going to need some help. I'm not going to want to necessarily, be the only set of eyes on my case at any given time. There are things that you can't see, from the mirror. You know what I mean? So, that's kind of what we want to share, is that I want to be available for all my patients in all my locations, so that we can actually be there to pay attention to and manage. Like, let's not bother the field doctor with those, you want to ask, 5
like
questions.
a CBCT question.
Yeah.
Right. So when, and this is actually real life, we take a lot of CBCTs, and a lot of times patients would like to get feedback on that. If you have more time to dedicate 100% on a CBCT review or reviewing their scans or the pictures and then doing a virtual, the patient gets a higher yield than running around doing that real quick in one of the operatories. Right?
You know how kids say the darndest things, right? Patients sometimes ask the darndest questions at the worst times. I want to be there to answer your question, but I mean, can't you see we have 80 people in the waiting room and I have a chair full? Like, no, this is not the best time for me to sit down and review your CBCT with you. And
For
that's
those
okay.
patients, when we take those CBCTs, we can schedule a virtual with Dr. Newaz versus doing it the day of when the whole office is filled up.
Yeah. So those are the kind of concessions that we hope that our patients can give us, and that's, of course, that's what I want to free myself up for. Of course, more as a radiologist and diagnostician. And of course, we will have people that can do a lot of the attending to, and like at least we stand out in that regard. That we want to be essentially the best place to go if you want a really good set of hands in your mouth, but also eyes on your case, right? And at least for me, as a provider, a big part for me, especially with my background and training, is going to be taking that step back from running around to all these offices and being in a place where I can really sort of dedicate my attention to every single patient that has consulted with us.
Don't fear, he'll still be visiting
Well, I will be
all
more.
offices.
Well, I'll be more present.
But you'll be more present.
I'll be more present because I'm not running around and I'm not basically swamped in the actual circumstance of the clinic day, right?
Yeah.
And I'll probably be busier, but that's okay. I'll be busier in the right way.
To utilize all of our strengths in the right.
Exactly.
Yeah. So we all have different strengths, so we should optimize them.
Absolutely.